Welcome everyone to Breakout Session 2. Welcome to everyone here in the room in the Las Vegas office. Also, welcome to those of you in the room at one of our other sites in Oregon, New Mexico, or Utah. My name is Jill Creston, and I am the Assistant Director of Quality Improvement here at HealthInsight Nevada. I'm also the Nevada QIO State Lead for the Care Coordination work. Before we begin, some logistical information. We'll be inviting questions and comments throughout the session using the same technologies we've had all morning. So cell phone, computer, or the old-fashioned way, there should be cards and pens on the table. So just hold those up if you have a question, and one of my colleagues will make sure they get up to the front. In the room with me, I have, sorry, getting a little feedback here. In the room with me, I have a couple of my HealthInsight colleagues. I have Margarita Bondrenko up here as our chat monitor, Lily Mesmanian right here, who is our timekeeper, and also Erin Hubbard right there, who is our room manager. So if you have any technical issues, just flag one of these people down if you're in the room. Now on to the main event. I would like to briefly reintroduce Mike Silver, one of our keynote speakers from this morning. Mike is the Senior Vice President of Improvement Sciences and Consulting Services for HealthInsight. He was introduced this morning, and his full bio is in the workbook. So Mike has expertise in human factors psychology, reliability engineering, and root cause analysis. We are lucky to have him today to talk about process reliability.
Let me see if I can, yes, it seems that every time I try to make it better, it makes it worse. All right, we'll go with that. Oh, there's me. There's Jill. Okay, so thank you for coming to a session on process reliability. By way of introducing the session a little bit, I'll talk a little bit about process reliability, and that we're not going to talk about all of process reliability. Process reliability is a huge topic. There's a giant experience and evidence base. There's science behind this. There's various approaches and disciplines associated with them, and we won't cover them all this afternoon in a 1-hour session. However, if you're interested in learning more about this, we'll introduce some key principles and their applications. And if you're interested in learning more about it, let us know in the evaluation notes and things like that, and we will schedule additional webinars or even workshops, that sort of thing, depending on the level of interest. We have HealthInsight's actually invested a lot in learning about this. Actually, a lot of it through our patient safety work. So what we'll be focused on this afternoon is distilling this to a couple of high leverage principles and applications of process reliability, really applied process reliability then. And we'll start with the graphic you have on the screen here or wherever you are. That is at the heart of the things we examine, or the way we might organize our thinking about process reliability. What this is supposed to represent is what happens in the course of delivering care, in the course of our work, happens dozens of times throughout the day. That we have some goal we're seeking to achieve, a patient goal or some other goal, and we have a plan for how we're going to achieve that. We take some action. We can verify that that action has produced the desired results. And based on the results of that verification, we may seek to learn about either the plan or the action, the sorts of things that come upstream. Okay, so I want to start us out with, hey, I'm going to pause for just a minute. Do we have a technical problem, or are we okay? Do I need to pause? Okay. All right. So I want to start out with some useful principles that'll guide the work that's going to follow here. A key principle that comes out of process reliability is focus on something that matters. Okay? On the way to creating a perfect healthcare system, and we're all on our way there, we may as well make the first steps we take or the next steps we take meaningful ones. Okay? The most meaningful, so we look for the highest leverage changes that we can possibly implement. Because frankly, we don't have time for others. So that's our first principle. Second principle, consider the user. So all these, every time when we see an act here, there's a person behind that act, right? Or a team behind that act. And we can ask questions about that user. Are they subject to distractions? Are they working under time constraints? Are they facing goal conflicts? Those sorts of things. Those types of problems, those types of issues may influence the quality, correctness of the action that is taken. Overall reliability is an important consideration here in process reliability. I'll give you an example. So we can make a suitably reliable system out of components that have failure rates. For example, as long as I have a spare tire in my car, I don't need a perfect tire on the wheel, right? Because between those two components, between an imperfect tire on the wheel and a spare tire in the trunk, I have a system that has a suitable level of reliability. So the tire doesn't have to be perfect, which is good, because I can't afford a perfect tire. But I can afford a suitably reliable system. And invest in learning. So in this Plan, Act, Verify, Learn cycle, the learn is somewhat optional. There is a lot of potential to not get the results you want and still not learn from it. You have a choice there in how much you're going to invest there. So that's by way of orientation. There are a number of reasonable, very good, strong approaches to this, to learning about it and ensuring process reliability. And for many of you, the perspectives would include classical quality improvement approaches. You would see process reliability approach through run charts, statistical process control, that sort of thing. And those are good tools that will help us move forward as well. There's even an entire discipline you can study. You can get degrees in something called reliability engineering that uses yet another set of tools. And it provides insights into where are the critical functions, where is it important to build in redundancy, where is a high leverage, that sort of thing. It's useful discipline. We won't be talking about those two as well. Most of what we'll be talking about today comes from another discipline. It's known, as you might recognize it, as mistake proofing. The idea of that can take on a couple of forms. Mistake proofing can provide barriers such that defects never progress beyond a certain point. They get caught. Or there's a related process, more related to what we'll talk about today, called source inspection. The idea being before something moves on in the process, we make sure it meets the expectations, and if it doesn't, we correct that before it moves on. And so what we'll talk about today is more closely related to that. So we're going to talk about in two chunks, three behaviors or three applications of reliability strategies. The first one is it acts on the verify stage here. And this is teach back with patients. And then the second one, now there are other forms, but this is what we're going to talk about today. We're going to start with a teach back. Jill will walk us through that. And then in the second part of today's session, we'll talk about techniques associated with prospective risk management and incorporating patient goals. These both come into our planning stage. So with that, I'm going to turn it over to Jill, who will talk about teachback and its applications to process reliability.
Okay, as Mike said, our first process reliability principle is work on something that matters. So these are the critical tasks, steps, and functions. Perhaps the most important reliability gap we have in all of healthcare, and this is across conditions and across healthcare settings, is the gap between the plans we make with and for our patients and the patients actually following through. Teachback is one of the most powerful verify techniques we have available. It can help us detect and correct a wide range of problems. For example, when the patient doesn't understand the instructions, or if the patient understands but either is unable to follow the instructions, they don't have the resources, or they just have no intention of following the instructions. They don't see the value. So what is Teachback? Page 9 in your workbook gives you a one-pager on the Teachback technique. It includes several websites and resources that you can use to master this technique, but you can also share them with others within your organization. Teachback is a research-based patient communication and engagement approach in which a provider gives information to the patient or family member and then invites the patient or family member to then teach back to them to explain what they just heard in their own words. And then the provider can either re-explain and reassess as many times as needed. So how do you do Teachback? Step 1, you start with open-ended questions. And I have up on the screen several examples of open-ended questions. Things like, can you tell me in your own words what symptoms you're looking for? What food should you avoid? No yes or no questions up here. The next important step is listening. And listening well is a crucial component to detecting whether the message is coming across clearly or there's still some confusion. For any areas of confusion, the provider should then re-explain in a slightly different way and then finally assess again. So step 4 is the reassessment. Here are some tips to successfully applying Teachback. 1, speak slowly and clearly. 2, break messages into short statements in either one sitting or multiple sittings. If you're sending a patient away with a long list of instructions, you don't have to wait till the end of the visit or the end of the hospital stay to start communicating these instructions and to start using the Teachback method. Use plain language. Avoid medical jargon and acronyms. Look for signals from the patient. If when you explain filling the prescriptions that the patient needs to fill, and you sense some hesitation or the patient looks away, ask a couple more questions. Demonstrate where possible. So show a patient the inhaler and show them what it looks like and it sounds like to be used properly. Finally, create a shame-free environment. Many patients are intimidated by medical professionals, so it's important to apply the Teachback method in a way that doesn't make the patient feel inferior. Some phrasing that I like for these open-ended questions are, let me make sure I explain that clearly enough. Can you tell me what to do? But also, how would you explain this to your spouse? So things like that could help make the patient less intimidated. So next we'll do an activity. Teachback activity is on page 8 in your workbook. I want you to think about how you can apply Teachback in your current role or within your organization. And these steps will help you think through how you can apply this. So how can you use Teachback? What would it take to apply Teachback in your organization? Who needs to be involved? Does there need to be training? And then finally, how would you verify this? How do you know you're being successful? How do you know it's being applied consistently? So we have about 10 minutes to complete this exercise and discuss with others at your table. And for those of you listening, we'll take about a 10-minute break, and we will come back at 2:10 Pacific time.
Sound like that.
Yeah.
When you turn the mics off, this is a really small system, and we've expanded it
Okay.
kind of further than we should have. So when this mic turns off, it'll feed noise back into the system. It's just static, just kind of cycling through. So just leave this on. Yeah, because test. Hello, test. Check, check. Hello, test, check.
Test works. Yeah.
Yeah, so just go ahead and leave it on, and then if you need to speak, just bring it over and just kind of pull it away.
Perfect. Thank you.
Cool?
Thank you.
All righty.
All right, everyone, it's about 10 after. Hey, Fern. All right, everyone, it's about 10 after. You wrap up the conversations. All right. All right. Can everyone hear me in the back? Aaron? All right. So we do have a couple minutes, and we have had some great questions and comments coming through. So if it's okay, I'll invite Mike Silver back up here, and we'll do some of the comments. Great. Margarita, go ahead.
Okay, so I wanted to share some of the comments through the chat. One is, I guess, a bit of advice. To listen well, say to yourself, wait, why am I talking? A few other comments we received. As a nurse, I always ask patients, show me after a procedure is taught. When I worked the floor, I could see the patient wasn't following what the doctor was saying. I would come in and say, would you like me to tell you what the doctor just said? That would cause a laugh, and they would relax, so they'd listen better. One hospital did staff orientation to teach back, oriented on the unit as to how it's used, has seen reduction in readmissions, and sees direct connection.
Okay, very good, thank you. So let's say, let's take a look at this. So here's a little something that happens in process reliability. We'll talk about this, then we'll go on to another topic. So if we introduce something like teach back or start doing it more reliably, one of the things that this happens whenever you do, this is called, like I said, source inspection. Whenever you do a source inspection program, what you do is you find a bunch of stuff that you've been missing, a bunch of problems upstream that you didn't know about because you weren't catching them through source inspection. So at first, this is, if you think, well, okay, if you haven't been doing much teach back and you start doing it, it's really inconvenient at first because you find all these problems that you've been letting go through your system that now you got to go and fix. And you got to fix them at first in this moment for this patient. We got to fix them, but at some point you're going to get tired of that and say, if we can go upstream a little bit, we could have avoided this to begin with. If our plan was correct, or if our action was more reliable, we wouldn't have this sort of problem. Is somebody familiar with this back here in the room? Somebody. Sorry, we should turn the camera around. Somebody's already experienced this, and we'll take it up in the chat at some point. Okay, so now we're going to switch topics to another related process reliability approach: prospective risk management and incorporating patient goals. Again, we're going to come back to the principle of doing something that matters, doing something important, focusing on something important. One of the most important things we can do in our systems is take deliberate action to try to anticipate and prevent risks from becoming problems in the first place. So we're focused now on the plan part of this process. Of course, you're asked to do this all the time, right? You're always expected to be aware, to be applying critical thinking. But what I'm talking about here is a specific focus on stepping outside of the production process and taking a deliberate prospective risk management step to avoid future problems. Not squeezing this sort of thing in on the margin, but carving out space for it. And when we do so, to ask the patient themselves about their goals and concerns. Let me review a couple of examples. We've come across, this is something that you can expect if you're working with HealthInsight, you will hear more about. The Medicare annual wellness visit is a relatively new Medicare benefit. It's a Part B, it's covered under Part B. It includes, so depending on, you can have a welcome to Medicare visit in the first year of Medicare and then every year after that. It's a dedicated visit that covers things like, would include the health risk assessment, medical family history, so you'd go over all the current medications and treatments a patient is undergoing. There's a screening for, you would be expected to screen for depression, assess functional level, safety, falls risk, develop a screening schedule, immunization schedule, all those preventive services, you would talk about that at those times. Treatment options, health advice, end-of-life planning, the sorts of things that you're expected, if you're, depending on your setting, you might be expected to squeeze in the middle of everything else. Well, there's a dedicated benefit for it established a few years ago under Medicare. We're pulling together data on this currently, but right now our best sources indicate that only about 20% of Medicare beneficiaries currently take advantage of this benefit. So it's hard to, and we're talking about moving upstream, we're talking about preventing problems. It's hard to prevent problems if the only time patients come to us is when they're having a problem, right? So this is an example of an opportunity that's actually part of the Affordable Care Act that changes the payment structure to support more effective care. So what if we're not this type of provider, a physician or a clinic that would provide an annual wellness visit? The same type of principle can be incorporated into most of our forms of care, right? Before I go there, even if you're not a clinic, even if you're not a provider of that type of service, you could recommend it to your patients. So everybody's got that option. But the same principle potentially applies wherever we are. Wherever we are, there's some intake, process at the beginning of our relationship or encounter with a patient. And the question is, can we incorporate that same type of thinking? What is the thinking behind an annual wellness visit? The thinking behind it is, gee, what kind of risks might this person be subject to? And what can we do about it to prevent to head those things off now? All medical or clinical processes have that sort of thing. We can ask how well those are working for us. When we're doing home health intake assessment, are we really anticipating or identifying the needs of the patients? We're working with, currently we're working with nursing homes on reducing the use of avoidable use of antipsychotic medications. The assertion would be, or the question would be, is it, okay, if I understand it right, and remember, nobody warned you about this. I'm a mathematician, so I don't really know anything. So I'm not a clinician, but here's the way I think. So if I understand it correctly, the use of antipsychotic medications in nursing homes is something that providers aren't eager to do. It's something that is done when other options feel like they've been exhausted. The question is, so how can we expand the options available? One of the ways so a couple strategies. How do you expand the options available? One is, when there's a crisis, identify a bunch of different options, right? The other one is, can we move upstream and avoid the crisis to begin with? Are there options that are here 3-6 months in advance of the crisis? The options dry up once you get down to a crisis, right? But 3-6 months, a year ahead of the crisis, there are options, there are different options. And that's what prospective risk management is about. So that's the type of thinking that we're seeking to review and introduce here. So here's our exercise or activity for this. It's in your workbook, page 10, and it asks a couple of questions. If you're an outpatient clinic, the first question is, how can we promote increased participation in our annual wellness visits? Annual wellness visits. That's one. If you're not a clinic that does that kind of service, then ask yourself or review, how can we improve our risk management processes, intake and assessment, based on what you know about your current processes and capabilities. And then for both groups, when we're doing that, when we're doing whatever that prospective part is, how can we incorporate patient goals, asking the patients about their health goals or their life goals into this prospective care planning? Why don't we take, how are we doing on time? Are we good on time? Okay, why don't we take 10 minutes on that exercise and come back at 31 minutes after the hour. So we'll give you 10 minutes.
The information at the back? People have written to me, which is like about 3 very active participants.
Okay. We can't tell the track actual.
There has to be some way of doing it. I'm not able to see it in this view. But you may be able to go there, because I think that's really the presenters.
Oh, I don't want to break anything at this point. That's such a good run. Oh, here.
It's no. We won't. We'll just find out later. No.
So the wellness program for hospice, so we're trying to convert the question into helping you make them aware that palatable. That shows when the doctor, whether it's the oncologist or the PCP, has concluded that the patient has an expectation for a certain period of time to live. How long it published? Is that projection, how accurate is that projection? Is it 50% of the time? Is it 10% of the time? So I have 6 months to live. Do I really have 6 months? Or do I really have 5 weeks? But there has to be substances that are, been accumulated somewhere. because those patients could be, readmitted 2 years later. Well, it's about 10%. Right now we have 55. And if we look at the population, we have got this year, others at all. We can still
Got leisurely, almost 15 minutes to the switch over to action planning. It's a good group. All right. Oh, thank you. We have okay, perhaps let's get started again, or come back together as a group. So thank you. And in fact, people have so much to share.
So much.
A lot of great discussion, and thank you for that. And so let's review a couple of. Thank you, Fern. For the folks not here in Las Vegas, we have Fern in the room, and she's banging away on a gong, trying to get attention. So here we go. What I thought we'd do is check in on a couple. We got a few minutes built in here. Comments that came in through the chat, and I know we have some comments that we're capturing in the room that we'll share as well.
Sure, lots of great comments from Oregon. To list a few, one learning. Registered dietitians can perform the AWV and bill for it, and the one who mentioned it indicated they're happy to do so. Another comment, one hospital is planning to have the screening questions covered in initial admission intake via Epic. Similar nursing homes, understanding a person's patterns, habits, substance history can go a long way in avoiding emergency use of medications for behavioral expressions of distress. Hence asking these questions in nursing home admission.
So moving upstream, that prospective risk management, fantastic, thank you.
And from here in Nevada, we have a few comments. Dental is also an important component of wellness. Mm-hmm. Adults are unlikely to take time off of work for a doctor visit if they are not sick. More large employers should consider offering wellness visits on site.
Oh. So again, we're thinking actually of a different user there, changing the cost of the annual wellness visit. The cost from a person, from my perspective, not only involves money out of my pocket, but if I got to take off an afternoon, that's a cost that I may or may not be willing to incur. So to consider from that design perspective. I appreciate that. Outstanding. So let's see. Maybe I'll just do a little bit of summary here on what we talked about, what we heard about today. So coming back to our, we try to make a link between process reliability, which is a vast and diffuse and interesting discipline, and a particular behavior around teach-back that Jill walked us through. And we made that link based on a couple of key assumptions. The biggest one being, remember the process reliability principle that we want to apply, work on something that matters. And we made the assertion that patient engagement is the least reliable function in all of healthcare. It's even less reliable than hand hygiene. And it matters, right? If the patient doesn't understand what they're to do, if they don't, or if they understand it but never intend to do it, or if they understand it and don't have the resources to do it, and we don't figure that out, then a lot of bad things happen. Okay? So far that would be unfortunate, right, that we have a performance gap. But it's important because not only do we have a performance gap, but we have something that we can afford to implement, that is teach-back, that has a lot of impact on this. Now, it doesn't perfect it, but it's worth pursuing. Just like